So now onto the pathologies of secondary hemostasis. These can be divided based on which part of the secondary hemostasis has been affected. These include, number 1, factor deficiency, including individual factor deficiencies, conditions known as the haemophilias, vitamin K deficiency, and liver disease. Number 2, pathological activation of the coagulation cascade, so a condition known as DIC. Number 3, excessive fibrinolysis, so where there is overactivity of plasmin. Number 4, pathologies that cause thrombophilia, where there is pathological intravascular thrombus formation. Conditions that cause this include antithrombin deficiency, proteins C and S deficiencies, factor V Leiden, prothrombin gene variant, hyperhomocystinemia, antiphospholipid antibody. And finally, we shall discuss drug reactions, including heparin-induced thrombocytopenia. So let us first discuss the haemophilias. Now there are 3 types: Haemophilia A, Haemophilia B, and Haemophilia C. Haemophilia A corresponds to a deficiency in factor VIII. This should be easy for you to remember, as A and 8 kinda sound the same. Haemophilia B is a deficiency in factor IX, so the next letter is the next number. And finally, Haemophilia C is a deficiency in factor XI. So remember, factor 10 is the goal, so we don't really want to mess with that, but we can lose the next number, which is 11. Keep in mind that all of these factors are part of the intrinsic pathway. Haemophilias A and B are both X-linked recessive disorders, whereas Haemophilia C is an autosomal recessive disorder. However, these disorders can also arise de novo, meaning they can arise as a new mutation without a family history. The clinical features of all the haemophilias include deep tissue and joint bleeding and post-op bleeding. Now, Haemophilia B is also known as Christmas disease because factor IX is also called Christmas factor. Haemophilia A is the most common, B is rare, and C is rarer. So if we consider the following investigations, pause the video and have a guess at what you might find for each of the haemophilias. The APTT would be increased in all 3 haemophilias. The reason for this is that all the factors are part of the intrinsic pathway, and the APTT, remember, measures the intrinsic pathway. The PT would be normal because the extrinsic pathway is intact. The platelet count would be normal because nothing is really affecting the platelets. The bleeding time is normal because primary hemostasis is present, and von Willebrand factor is also normal. You're probably wondering why we are measuring von Willebrand factor. This will make more sense to you once we discuss von Willebrand's disease, but don't forget that von Willebrand factor is also a carrier for factor VIII. So how can you differentiate between all 3 types of haemophilias, as they all present with the same clinical features and have the same blood work? Well, you can measure individual factors and you'll see a deficiency in factors 8, 9, or 11, depending on the type of haemophilia the patient has. Treatment of haemophilia is by replacing the factors, so you can give a patient recombinant factor 8, 9, or 11, depending on what type of haemophilia they have. If a patient presents with a mild haemophilia, for example mild Haemophilia A, you can consider synthetic vasopressin such as desmopressin, which increases the deficient factor. Now, importantly, 30% of patients develop antibodies against the recombinant factors. In this case, you would treat the patient with activated recombinant factors. The most common cause of death in haemophilias are cancers and heart disease. The main complication of haemophilias include increased risk of intracerebral bleeding and deep tissue or joint bleeding, and there is also a small or low risk of HCV and HIV infections from multiple transfusions. However, these are extremely rare now that all blood is thoroughly checked and screened. And finally, You need to know about factor VIII autoantibodies and how to differentiate this from haemophilia A. The causes of factor VIII autoantibodies include malignancies and autoimmune conditions such as lupus. They can also occur in the elderly. The clinical features are the same as haemophilia, but this is not a true haemophilia A. So how can we differentiate? Well, there is a test called the 50-50 test, where you mix the patient's plasma with normal plasma and then measure the APTT. In patients with factor VIII autoantibodies, the 50-50 test does not correct the APTT, as antibodies are still present, and these bind to factor VIII and inhibit coagulation. In haemophilia A, the APTT is corrected, because the normal plasma provides a source for factor VIII. So now on to von Willebrand disease. This is the most common inherited coagulation disorder. The reason why I'm discussing it here and not in the primary hemostasis series is because in addition to von Willebrand acting as an anchor for platelets to bind to damaged endothelium in primary hemostasis, von Willebrand factor is also a carrier of factor VIII. This is an autosomal dominant pathology. Von Willebrand factor is found on chromosome 12. So in von Willebrand disease, you have a deficiency in both von Willebrand factor and in factor VIII. So just to quickly go over the pathophysiology, platelets cannot adhere to the damaged endothelium due to a lack of von Willebrand factor, so primary hemostasis fails. There is also failure of the intrinsic pathway of the coagulation cascade, as factor VIII is not present, so the intrinsic pathway cannot reach nor activate factor X, which is, if you remember, we said is the goal of both the intrinsic and the extrinsic pathways. The clinical features are sort of a combination of both mucocutaneous and deep tissue bleeding, as this pathology affects both primary and secondary hemostasis. However, patients tend to present more with mucocutaneous features, including epistaxis, purpura, menorrhagia, and gingival bleeding. So let us consider the following investigations. Again, feel free to pause the video and have a guess at what you might find. Now, the APTT would be increased. This is because von Willebrand factor is deficient, and in the absence of von Willebrand factor, there is no carrier for factor VIII, so factor VIII would also be deficient, and the APTT would be prolonged. The PT would be normal. This is because the intrinsic pathway remains intact. The bleeding time would be increased due to poor platelet adhesion. Again, there is no von Willebrand factor to allow platelet adhesion to the damaged endothelium. Platelets can be normal or mildly low. Von Willebrand factor itself would be low, again because this is the pathology of von Willebrand disease, and factor VIII would also be low. Again, in the absence of von Willebrand factor, there is no carrier for factor VIII. In terms of treatment, you can use desmopressin. Desmopressin increases von Willebrand factor release from the endothelial viable Palardi bodies. You can also directly replace von Willebrand factor. In active severe bleeding, you would transfuse von Willebrand concentrate, consider platelet transfusion, and consider use of antifibrinolytics. You should also treat specific symptoms, for example, treating menorrhagia with the use of oral contraceptive pills, desmopressin, or an intrauterine device. The mainstay treatment for von Willebrand disease is the replacement of von Willebrand factor. So let us now talk about vitamin K deficiency. The easiest way to understand this pathology is to ask yourself a few questions. We'll go through these questions so that it makes more sense to you. First, what is the importance of vitamin K? Let us here describe the physiology. So when factors are being synthesized or made in the liver, the factor precursors need to be converted to their functional units. This is achieved by gamma-glutamyl carboxylase, which basically causes carboxylation of gamma residues on specific factors. Now, gamma-glutamyl carboxylase requires vitamin K as a cofactor. Vitamin K is oxidized during the process. Now that we have oxidized vitamin K, we need to recycle this so that it can be used again and help make more factors. It is reduced by vitamin K epoxide reductase. This is a very simple way of putting it. So again, we have factor precursors, we want functional factors. These precursors undergo gamma carboxylation by gamma-glutamyl carboxylase. Gamma-glutamyl carboxylase requires vitamin K as a cofactor. Vitamin K is oxidized in the process, but we need to recycle this vitamin K so we can use it again, and this recycling is achieved by vitamin K epoxide reductase. The vitamin K dependent factors are 2, 7, 9, 10, S and C. You just need to keep repeating this to yourself so that you can recall it when prompted. So again, 2, 7, 9, 10, SC, 2, 7, 9, 10, SC, 2, 7, 9, 10, SC. The second question to ask yourself is, where is vitamin K generated? The main source of vitamin K synthesis is by gut bacteria. Other sources include leafy greens, cauliflower, and liver. Now, the third question to ask is, where is vitamin K absorbed? Well, vitamin K is a fat-soluble vitamin. Can you recall the other fat-soluble vitamins? These are A, D, E, and K. Vitamin K is absorbed in the jejunum and the ileum. So now we can ask, what disorders cause vitamin K deficiency? Newborns have a vitamin K deficiency, although this is not a disorder. The reason for this is that in newborns, the gut has not yet been colonized. There is also poor placental transfer of vitamin K during pregnancy, and breast milk contains very little vitamin K. This is the reason why newborns are given a vitamin K injection as soon as they are born, to help their blood clot and to prevent serious bleeding. Long-term antibiotic therapy can also cause a vitamin K deficiency because they can disrupt gut flora. Malabsorption syndromes can also cause a vitamin K deficiency, including cholestasis. The use of warfarin, an anticoagulant, can also cause a vitamin K deficiency, as we shall later see. We can now look at the investigations. What would the APTT and PT show? Pause the video and have a think. Now, hopefully you understood that both of them would be increased. And the reason for this is that we need to consider the vitamin K dependent factors, which are 2, 7, 9, 10, SC. Now, factor 7 belongs to the extrinsic pathway, which is measured by the PT, and factor 9 belongs to the intrinsic pathway, which is measured by the APTT. So deficiency in these two factors would increase the APTT and the PT. Factor 10 is the goal of both pathways and is part of the common pathway. So a deficiency in factor 10 would increase both the APTT and the PT. Now we can ask about the clinical features. These would include purpura, hematuria, GI bleeding, and cerebral bleeding. Basically any sort of bleeding. This is because coagulation factors 2, 7, 9, and 10 are not being produced, so the risk of bleeding has been substantially and significantly increased. You can treat vitamin K deficiency by giving IV vitamin K1. This is also used to reverse the effects of warfarin. We can also ask, how does warfarin actually work and where does it act? Well, warfarin is a vitamin K epoxide reductase inhibitor. So basically it prevents the reduction and recycling of vitamin K, so less factors are being produced. We shall discuss warfarin later in the haematology pharmacology series. Finally, liver failure can also result in factor deficiencies. This is caused by, first, decreased synthesis of coagulation factors in liver failure, Second, decreased vitamin K through either intrahepatic or extrahepatic causes. And third, DIC can occur in acute hepatic failure. In the next video, we shall discuss DIC, which is the pathological activation of the coagulation cascade.